Good afternoon. I am Dr. Ramkumar, Associate Professor from Department of Psychiatry. Today, the topic of discussion will be disorders of sexual preference. So, today we will be covering these objectives. And that is, at the end of this session, you will be knowing all these details. This will be seeing about history, about these disorders of sexual preference, and definitions from various contexts and the epidemiology of this disorder and cause, that is etiology of these disorders, types of different disorders of sexual preference, and what are the differential diagnoses when we encounter this disorder of sexual preference, and what all the psychosexual assessment has to be done to such patients, uh, and what all the treatment modalities available, and finally what are the ethics and laws related to these disorders of sexual preference. Finally, there will be conclusion. So we'll be seeing one by one. So coming to the history, Richard von Graf Ebing, a German psychiatrist only, first identified paraphilias, and he recorded in his work in 1886 in the book named Psychopathia Sexualis, that is sexual psychopathy. So he is the one who worked very extensively, and he is the pioneer in this field. Followed by him, Sigmund Freud held that human sexuality advanced through different stages. So he gave different type of stages of psychosexual development, like oral phase, anal phase, latent phase, genital phase. So he gave different stages where the human beings develop based on the different form of stages. Their sexual preference varies. So he theorized that individuals who progress toward normal heterosexuality unless prevented. So according to his theory, if the person is not deviated during the psychosexual development, he lands to a normal heterosexual living. Whereas if there is any deviant, there might be homosexual or disorders of sexual preference will be noted. So he saw all paraphilias as infantile, that is not mature sexual behavior. So according to him, the person who is having paraphilic disorder is, that is, he has not developed the proper psychosexual development. He is stuck in any one of the stage before to the mature stage. Coming to the definition, paraphilias are defined as sexual disorders which are characterized by recurrent, intense, sexually arousing fantasies, sexual urges, or behavior generally involving non human objects. The suffering or humiliation of oneself or one partner, or children or other non consenting individuals that occur over a period of 6 months. So, this is criteria A, which cause clinically significant distress or impairment in social, occupational, or other forms of functioning. That is criteria B. So, according to DSM-5, they have to fulfill this both criteria A and criteria B. So, according to criteria A, the recurrent intense sexual arousing fantasies or sexual urges or behaviors generally involve either non-human objects, the suffering of humiliation of oneself or one other partner, children or non-consenting individuals that occur over a period of 6 months. So, and there should be some impairment in the socio-occupational functioning. This is as per DSM-5. As per ICD-10, has less strict and less detailed criteria referring to the particular object or act as being the most important source of sexual arousal or essential for satisfactory sexual response. That is, if you see in the disorders of sexual preference, even not doing the sexual activity, for example, uh, in voyeurism, even if they peep or even if they see a sexual act, they attain the sexual pleasure. That is, they don't pass a normal role of a human being. That is the difference. So here they give criteria as a particular object or act as being the most important source of sexual arousal and are essential for satisfactory sexual response. So, what are the different common paraphilias we encounter? Exhibitionism, that is exposure of genitals to a stranger. Then pedophilia, sexual activity with a pre-pubescent child, generally 13 years age or younger. Voyeurism, observing other sexual activities. Fetichism, use of inert objects such as female undergarments. And transvestic fetichism is cross-dressing, male dressing as female, female dressing as male. And sexual sadism, where inflicting suffering or humiliation to the partner. And sexual masochism, being humiliated, beaten, bound, or made to suffer. Here, the person themselves want to make them suffer. In sadism, the opposite person will be made to suffer. That is, by making an opposite person suffer, the other person will enjoy the sexual pleasure. In masochism, it's opposite, where the person in themselves they want to be get humiliated. And Freudism is touching, rubbing against a non-consenting person. So these are the definitions given as per the DSM 5, sorry 4, where fetichism, non-living deal with non-living objects. For example, they will see the clothes, shoes, rubber of this person whom they are following, and fetichistic transvestism and transvestic fetichism. So we are comparing both the ICD-10 and DSM-4. Here there will be cross-dressing will be noted, and exhibitionism is both common in both the DSM-4 and 10, where exposure of genital changes. Voyeurism is also same, watching others who are naked, disrobing, or engaging in sexual acts. Pedophilia is same in both, where children usually less than 13 are being used for the sexual act, and sadomasochism. Here in ICD-10, both sadism and masochism, also sadomasochism disorder, whereas here so masochism is a separate entity and sadism is a separate entity, where as I mentioned before, sadistic persons will make others to suffer and enjoy sexual pleasure, whereas in masochism, the person themselves also want to get humiliated. Other disorders of sexual preference like paraphilias are not otherwise specified, and multiple disorders of sexual preference in ICD. Coming to the epidemiology, paraphilias are predominantly male sexuality disorders. So except for sadism and masochism, the paraphilias are almost never diagnosed in females, although some cases have been reported. So if you see, most of the cases reported in paraphilias will be males. And data gathered from more than 90 treatment programs throughout North America regarding around 2,129 cases of individuals seeking assessment indicate that 37% had been involved in child molestation, 20.2% involved in voyeurism, and 13.8% in exhibitionism, 13.3% in fetichism, 11.2% in frottage, and 10.7% in public masturbation. So these are the data who have been involved in the different paraphilias. And in another study, a study of 561 paraphilic persons who had committed more than 291,000 paraphilic acts against more than 195,000 victims indicated that of all victims, 37% victims are exhibitionism, 28.6% are of frottage, 13.6% of voyeurism, 1.8 percentage of molestation against boys outside the home, 3.5% of public masturbation, and 2.3 percentage of molestation of girls outside the home, 1% of obscene telephone calls, 0.9% of bestiality, 0.5% of rape of adult women, 0.2 percentage of molestation of girls in the home, 0.1% or less of sadism, masochism, fetichism, molestation of boys within the home. So obscene mailings, caprophilia or attraction to odors. Frequency of paraphilic behavior, exhibitionism 50.5, public masturbation is around 50% frequent, and masochism frequency is 36%, obscene telephone calls is 30%, protage is around 30%, transvestism is 25%, voyeurism is 16.5%, non-incestuous molestation of male victim is 10%, incestuous molestation of male victim is 5.2%. And incestuous molestation of a female victim is 4.4%, fetichism 3.3%, sadism is 3%, bestiality is 2.2%, non-incestuous molestation of a female victim is 1.4%, and rape of an adult woman is 0.9%. So, as of now, we have seen about the different epidemiological data of these paraphilias. Coming to the comorbid illness associated with these paraphilias, some paraphilic subjects show evidence of comorbid major axis 1 mental illness. That is, if you see most of the paraphilics, they suffer from any one of these affective disorders. If you see the data, it is around 3 to 95 percentage of people have been suffering from affective disorders. Substance use disorders 8 to 85 percentage, anxiety disorders 3 to 64 percentage, schizophrenia or other psychotic disorders 1 to 16 percentage, dementia or other cognitive disorders 1 to 4%, and ADHD 36%, and eating disorders around 10%. So these are the comorbidities associated with these paraphilias. And paraphilias may also occur with the context of axis 2 disorders, that is personality disorders. Most of the common personality is around 33 to 52%, and it is mostly seen in antisocial personality disorder. Coming to etiology, that is, what is the cause? Different types of etiological factors for this paraphilias. So they have given 5 theories, out of which biological theory, neurological theories, monoamine hypothesis, psychoanalytical theory, and behaviorist theory. So you see each theory one by one. In this biological theory, the neuroanatomical and neuroimaging studies of sex offenders indicates that congenital or acquired brain damage are overrepresented. So some pedophilic perpetrators show structural impairment of brain regions critical for sexual development. Subtle defects of the right amygdala and closely related structures might be implicated in the pathogenesis of the pedophilia. And in the neurological hypothesis, it is associated with frontal or temporal lobe damage. This damage may translate into an individual's inability to control sexual impulse or directly cause paraphilic behavior as a result of tissue damage. And monoamine hypothesis. Here, the monoamine hypothesis for the pathophysiology of paraphilic disorders was first articulated in 1997 by Kafka. So he worked on a lot of paraphilic patients. So this hypothesis was based on 4 converging lines of empirical evidence. Monoamine neurotransmitters serve a modulatory role in human and mammalian sexual motivation. So the sexual effects of pharmacological agents that affect monoamine neurotransmitters may have facilitative and inhibitory effects on the sexual behavior. So paraphilic disorders appears to have axis 1 comorbid associations with non-sexual psychopathologies and that are associated with hemorrhagic dysregulation. So pharmacological agents that enhance central serotonergic function in particular have been reported to ameliorate paraphilic sexual arousal and behavior. Psychoanalysts generally theorize that these conditions represent a regression to or a fixation of the earlier level of psychosexual development. As I mentioned before, Sigmund Freud has been worked extensively on this psychosexual developmental disorder, sorry, stages, where he connect all these paraphilias to this arrest or fixation of the earlier stage, and they don't get mature enough to appropriate to their age. So resulting in repetitive pattern of sexual behavior that is not mature in its applications and expression. Coming to behaviorist theory, the following are the situations and causes that might lead someone in a paraphilic direction. So parents who humiliate and punish a small boy for stuttering around with an erect penis, a young boy who is sexually abused, an individual who is dressed in a woman's clothes as a form of parental punishment, fear of sexual performance or intimacy. So I repeat again, the behaviorist theory is somewhat very convincing in this paraphilics to my experience. So if you see where the parents who humiliate or punish a small boy for stuttering around with an erect penis, a young boy who is sexually abused, an individual who is dressed in a woman's clothes as a form of parental punishment, fear of sexual performance or intimacy. So this behavior, these situations can lead to a behavior where the child can change turn towards a paraphilia. So according to behaviorist theory, inadequate counseling, excessive alcohol intake, psychophysiological problems, socio-cultural factors, psychosexual trauma are all the different forms where these are the stressors added to the change in the behavior. So we have completed the definition, then epidemiology, then etiology, that is causes for this development of paraphilic disorders. Now coming to the diagnosis and the clinical features. DSM-5 identifies 8 categories of paraphilias. So the activity must be sole means of sexual gratification for a period of 6 months, which I mentioned before, and should cause marked distress on or interpersonal difficulty in the socio-occupational functioning. The categories of paraphilic behavior are exhibitionism, fetichism, voyeurism, masochism, pedophilia, sadism, transvestic fetichism, and voyeurism. So paraphilias that do not meet the guidelines of these categories are called as paraphilia not otherwise specified. We'll see one by one these paraphilic disorders. Exhibitionism. Exhibitionism, also known as splashing or indecent exposure, is the exposure of one's genitals to a non-consenting stranger. So exhibitionism occurs predominantly in men with the peak age of onset of around 20. The individual is stimulated sexually by gaining the attention of and startling the observer. The exhibitionist often masturbates as a part of the exposure. So exposing oneself while driving or in a public place are the most common expressions of exhibitionism. Exhibitionism is one of the 3 most common sexual offenses in the police records. So the other 2 are voyeurism and pedophilia. A patient in treatment of exhibitionism is highly likely to engage in other forms of deviant sexual behavior and to suffer from depression or anxiety or substance use disorders. So if the opposite people or the non-consenting stranger getting startled itself will give a sexual pleasure for these exhibitionistic peoples. Next disorder, fetichism. So individuals who achieve sexual gratification with the use of objects, most commonly women's undergarments, shoes, stockings, or other clothing items, suffer from fetichism. Fetishists often collect the objects of their sexual gratification. Fetishism has been exclusively described in men and often exists with the other paraphilias. So here they prefer the non-human objects. So they don't need any, preferably they don't need any humans to get sexually gratified because based the objects itself they get their sexual gratification, like their undergarment, shoes, the objects used by the persons. So coming to Freudism. Freudism refers to the sexual gratification achieved by touching or rubbing a non-consenting person. The behavior often occurs in busy, crowded places such as on a busy streets, crowded buses, subways, where they purposefully they try to rub their genitals to the non-consenting persons, and they want to make a portray that it is because of their busy schedule or busy thing they are just like that moving away. But it is a paraphilic behavior. So this behavior often, as I mentioned before, busy areas, and Freudism is described only in men. So a Freuder may fantasize that the woman he is rubbing up against is mutually aroused by the behavior. So they think that because of doing so, they are giving the opposite person is also consenting for their act. And pedophilia, recurrent intense sexual urges and sexually arousing fantasies involving sexual activity with a prepubescent child or children. The pedophile has to be 16 years of age or older and at least 5 years older than the victim child. Although for a late adolescent, this age discrepancy is not specified, the majority of pedophiles are male. Pedophiles are categorized according to their exclusivity, the gender of child they are attracted to, and whether the child is familial, that is incest, or non-familial. A larger percentage of pedophiles are homosexual or bisexual in orientation to the children. 50 to 70% of pedophiles can be diagnosed as having another paraphilia, such as Freudism, exhibitionism, voyeurism, or sadism. So these pedophiles, the children will be the victim. And coming to sexual masochism, where sexual masochism is a term used to refer to sexual gratification produced by pain that is inflicted by others or by oneself. Sexual masochism is one of the few paraphilias described in women. The three main characteristics of masochism are pain, loss of control, and humiliation. So one of the psychodynamic theories postulated about this masochism is Freud's writing that masochism is derived from sadism. And sexual sadism is sexual gratification achieved from the implication of psychological or physical suffering or both on a partner. Sadists experience sexual fantasies involving the suffering of another as well as compulsions to enact their fantasies. A sadist partner may consent to the behavior in an effort to satisfy his or her own masochistic fantasies, or the partner may be the victim. So, Kraft Ebing subclassified sexual sadism into several categories, including lust murder, that is, the act ends with the murder, and mutilation of corpse or necrophilia, injury to females by stabbing, defilement of women, other kinds of assaults on women like symbolic sadism, in which, for example, the perpetrator cuts the hair of his victims rather than harming them directly. So these are all the subcategories of this sadism, sexual sadism. So ideal sadism or sadistic fantasies alone without acts. sadism with objects, for example, whipping boys, sadistic acts with animals. In some individuals, sadistic fantasies and compulsions lead to rape or homicide. So, fetichistic transvestism or transvestic fetichism. So, almost synonymous. The wearing of clothes of the opposite sex, principally to obtain sexual excitement. The disorder is to be distinguished from simple fetichism in that the fetichistic articles of clothing are not only worn but worn also to create the appearance of the person of the opposite sex. So usually more than one article is worn and often a complete outfit plus wig and makeup. Fetichistic transvestism is distinguished from transsexual transvestism by its clear association with sexual arousal and a strong desire to remove the clothing once orgasm occurs and sexual arousal declines, whereas it is opposite in the other. The history of fetichistic transvestism is commonly reported as an early phase by transsexuals and probably represents a stage in development of transsexualism in such cases. Voyeurism is a sexual gratification achieved from watching people undressing or nude or observing them during sexual acts without their knowledge or consent. Voyeurs are usually men in their 20s and 30s who prefer to watch unknown women. They may masturbate while observing their victims but typically seek no contact with the victim. Some voyeurs report sexual fantasies that the woman they are watching will solicit sex from them. The onset of voyeuristic behavior is usually before the age of 15. Voyeur tends to have multiple paraphilias and to cross over from one paraphilia to the another. Then other disorders of sexual preference, paraphilia, not otherwise specified, is telephone scatologia, that is using obscene words during the phone calls where they get the sexual pleasure. Necrophilia, that is attaining a sexual gratification or having sexual activity with the corpse, that is dead person. And partialism is exclusive focus on part of a body. Zoophilia is having sexual gratification with the or sexual activity with the animals. Coprophilia is uh, while sexual activity they use feces. The smell of the feces will give them a sexual gratification. Urophilia is similar like that with the urine. Clismophilia means the enemas. And autoerotic asphyxia means self asphyxiation. They themselves try to strangle it. Where they get sexual pressure, they become normal. So many individuals manifest multiple disorders termed polymorphous perversity. Polymorphous perversity has been used. Most common combination, if you see, fetichism will be there, transvestism will be there, sadomasochism will be there. And differential diagnosis, the diagnosis of a paraphilia begins with the identification of the individual's sexual interest. It is important to understand an individual's sexual preference before the diagnosis of a paraphilia can be made. For example, the differential diagnosis for a child molester may include pedophilia, personality disorder, mental retardation, or substance abuse. Now, we have seen different types of paraphilic disorders. Now, coming to the assessment. So, almost with the given criteria, we have some idea about which category of paraphilia the person comes. But that is not sufficient to come to a diagnosis. So we need to do a psychosexual assessment. The psychosexual assessment, sexual knowledge and sources of information should be as from the person, sexual attitudes to self and others, age of onset and development of sexual interest, masturbation, dating, sexual intercourse, relationship history, including age of self and partner, gender of partners, duration and quality problems, abuse, fantasy. So, what are the contents used, development in those fantasies? Then you should assess or ask the orientation or sexual orientation, whether they have orientation towards the opposite sex or towards the same sex, and drive frequency of masturbation, intercourse, or and dysfunction, specific inquiry about arousal, impotence, premature ejaculation, experience, a range of sexual behaviors with a specific inquiry about paraphilia, current sexual practices, mood, thoughts, visual images, material use, and conditions for arousal during both intercourse and masturbation. What does the person want from treatment? So, management. Do they want help at all, or have they just come as they have been forced by the family members like spouse or by the order by a court? Then, do they want to change the focus of the sexual arousal or desist from the overt behavior? Do they want to adapt better to the behavior without changing it? Are they motivated to engage in treatment? So, all these questions we should ask the patient. So based on that only, based on their motivation only, the success of treatment lies. Then investigation for such patients, physical examination, investigations may be indicated particularly if sexual dysfunction coexists. So what are the investigations? If there is any sexual dysfunction, we can go for penile plethysmography, polygraphy, visual reaction times may be useful in assessing paraphilias. In general issues, better adjustment without changing the behavior, resisting from overtly problematic behavior but retaining the deviant arousal, changing the focus of the arousal, and encouraging the development of normal relationship, addressing sexual inadequacy, develop interest activities or relationship that will fill the time previously taken by the fantasizing about preparing for and taking part in the deviant activity, decreasing masturbation to deviant fantasies and encouraging masturbation to more appropriate fantasies. Specific treatment, biological treatment, the scientific basis of biological treatment in paraphilia is the reduction of sexual behaviors by decreasing testosterone levels. Surgical treatment for sex offenders consists of two types: neurosurgery, that is, stereotaxic removal of parts of the hypothalamus, which is considered to be the area for these paraphilic behaviors, and castration, surgical and medical castration. Coming to pharmacological treatment, though it is not successful, some of the patients has responded for these anti-androgens, hormonal agents, selective serotonin reuptake inhibitors by reducing their sexual desire. So testosterone is the most common androgen in man. Anti-androgen treatment refers to treatment of drugs used to block the production or interfere with the action of the male sex hormones. Cyproterone acetate, medroxyprogesterone are the two most common used anti-androgen medications. Anti-androgens, reduction of testosterone has been used to reduce libido erections, ejaculations, and spermatogenesis. The risk associated with the use of anti-androgen agents include side effects such as weight gain, hyperglycemia, hot and cold flushes, liver dysfunctions, hypertension, muscle cramps, phlebitis, gastrointestinal complaints, and feminization. The patient who agrees to anti-androgen treatment should be educated about the absence of the long-term data. And hormonal agents like leuprolide, triptorelin are hormonal agents refers to as a long-acting gonadotropin releasing hormone agonist, that is called as GnRH agonist. These agents inhibit the secretion of luteinizing hormone, resulting in decrease in the plasma testosterone levels and libido. So the main motto of these drugs is they want to reduce the desire of the sexual activity. They produce a chemical castration in the hypothalamic pituitary axis is exhausted and there is a potent inhibition of gonadotropin. The side effects associated with GnRH agonists include decreased bone mineral density, osteopenia, weight gain, hyperglycemia, diabetes, hypertension, insomnia. The most commonly reported side effect is erectile or ejaculatory problems and gynecomastia. The preliminary studies of GnRH agonists suggested that leuprolide and triptorelin may be more effective, better tolerated alternatives to the anti-androgen treatments. And SSRIs, most commonly fluoxetine, sertraline, paroxetine, fluoxamine. These reduce the sexual desire. And psychological approaches to the treatment of sexual offenders focus on direct treatment approaches to modify the offenders' cognitions and attitudes. Cognitive approaches describe the concept of cognitive distortions as one of the factors maintain offender behavior. So CBT, that is cognitive behavior therapy, has been and continues to remain the predominant approach to the treatment of sex offenders or individuals with paraphilias. Its main treatment approach involves decreasing inappropriate sexual arousal through a variety of techniques like covert sensitization, masturbatory satiation, systematic desensitization. This approach also aims to enhance appropriate sexual arousal to adult partners through techniques such as orgasmic reconditioning. The other parts of CBT include cognitive restructuring, assertive skills training, social skills training, addressing intimacy deficits, sexual education, sexual dysfunction treatment, enhancing empathy and relapse prevention. So, what will be the course and prognosis of this disorder? Paraphilic behaviors emerge as adolescent and early adulthood. Although it has been shown that individuals may cross over from one paraphilia to another, the overall course of paraphilic behavior is chronic and it is very difficult to treat. Coming to ethical and legal considerations, as such, traditional codes of ethics employed in medical treatment are not applicable to treatment of sex offenders. A significant percentage of sex offenders receiving treatment have been mandated by the courts only, and they don't come for treatment by themselves. Individuals who reject treatment are subjected to punishment imposed by the courts. Individuals who have been court ordered to receive treatment do not have a choice regarding the treatment or treatment provider. The medical model patients have a right to refuse various types of treatments. The right to refuse treatment is based on the individual constitutional rights to privacy. The court views sex offenders as incompetent patients and such court becomes a decision maker regarding the treatment. In future directions, although studies have demonstrated effectiveness on some modalities of sex offender treatment, the scientific literature does not identify a definitely effective treatment. The future of the research in the treatment of sex offenders and paraphilias lies in the development of evidence-based knowledge that will inform both clinical decisions and public policy. This effort may be afforded by interdisciplinary collaboration between the scientists, scientific community, correctional professionals, and policy makers. So coming to the take-home message from these paraphilias, the paraphilias are more predominantly seen in males, and different types of paraphilias has been theories of paraphilia has been discussed. And as per DSM-5, 6 months activity should be present, and it should cause a marked interpersonal and socio-occupational distress. And various categories of paraphilia, the exhibitionism, fetichism, frotteurism, masochism, pseudophilia, sadism, transvestic fetichism, and voyeurism. And psychosexual assessment has been discussed detail, addressing the different types of general issues in paraphilic persons and different types of pharmacological treatment like anti-androgens and other hormonal agents, SSRIs. And coming to psychological treatments like CBT has been discussed detail. So these are the references for my topic for this session. Thank you for your patience listening. Thank you all.